women some problems, and I'd like to ask you to think a little bit about this in your contact with pregnant women. We have a huge dichotomy of belief about pregnancy, and I want you to think about this, because to work with pregnant women, I think you have to be able to think in two very different ways at the same time. Right? The first is pregnancy an illness? No. Okay. So there's this phrase that goes like, pregnancy is not an illness. You know, why are doctors involved with pregnancy? You know, why do we have all these male obstetricians who actually just want to control and do bad things to pregnant women? And there is something, you know, there's something to be thought about in the psychology of male obstetricians. There's a lot to be thought about as well in the psychology of female obstetricians, right? But the answer is, you know, pregnancy is not an illness, but it can still go horrendously wrong. So on the one hand, we know this fact that this is natural childbirth, right? 920 women per 100,000 die. Okay, this is highly medicalised childbirth with a huge amount of other social forces that operate around pregnancy, like having running water in your house, you know, having access, having good nutrition, space in your family, you know, value in education in women. Okay, so it's not just this is just to do with medical care. There's a whole load of social factors that come into it. But the fact is, there is a big difference between real natural childbirth and what happens in a developed country with well-developed medical centres. Okay? And that's the difference between these two figures. I should just say, I picked Pakistan because quite often there's a lot of people in the audience who will relate to Pakistan, right? But this isn't a bad figure compared to the developing world. Chad or Niger, which Central African countries that have the worst maternal death rate in the world, it's 1 in 20 women who die in childbirth. Okay, so it's phenomenal. That's the natural death rate from childbirth. And as I say, my granny thought it was normal. That's the whole generation, because they all knew that Mrs. Mackenzie up the road died, which was having our seventh child. So these are important figures. Now, on the one hand, pregnancy is not an illness. Women are told this quite rightly, and it's true. Okay. On the one hand, as people who work with childbearing women, we want those women to be honoured and respected, and we want them to be, we want their choices to be in terms of how they have the baby and where they have the baby. We want their choices to be informed, and we want to support their choices. We don't want to make silly value judgments about their choices. Okay? But at the same time, we have to be cognizant of this risk. Think how easy it would be to manipulate a pregnant woman with figures like this, and how coercive and kind of wrong that would be. How easy would it be to say, oh, well, if you don't do exactly what I ask you to do, you know, look at these figures, you'll die in childbirth. And you know, you will hear, we used to hear it quite a lot, and you don't come into hospital or stay in hospital, you'll have a stroke and die. And like, that's really not true. And it's like knowledge bullying. You're using a fact in the wrong way to make somebody else do something. Okay? When women make their choices about where they have their babies and who's involved with having their babies, there's all sorts of complex factors go in there. One is risk, and when I listen to young doctors counsel childbearing women, they talk a lot about the risks. They talk a lot about the risks of cesarean. They'll talk about the risks of having your baby at home. They'll talk about the risks of coming into hospital. And the truth, you know, what they're really talking about is relative risk. Okay? Because you may see, for example, cesarean has a 6 times higher death rate than vaginal birth. Now, that's true. Okay, if you look at the death rates for cesarean, it is 6 times higher than the death rates for vaginal birth. But those are the raw figures. There's all sorts of reasons for that, a lot of which relates to the reasons that a woman might be having a cesarean. Okay, if she has preeclampsia, has a cesarean and dies, it's more likely that she's died from the preeclampsia than she's died because of the cesarean section. But the 6 times higher death risk is a relative risk. What's really interesting is not the relative risk, but the absolute risk. The absolute risk of death is, in fact, it's 12 per 100,000, which is a very, very small number. Okay, so when we counsel women and when we think about risks, is having a baby at home safe? Well, we now have figures published very recently in the New England Journal of Medicine that shows much more of a planned home birth. But even though the risks are slightly higher than hospital birth for a low-risk woman, the fact is that most of the time it goes without a problem. Most of the time there are no problems. When we counsel pregnant women, there's much more to it than the risks. Women are interested in a lot more than just what's the risks of this and what's the risks of that. You probably all drive a car, and that involves taking risks, right? Because you'll trade the risk off against the value of driving a car. You think, well, actually, I want to drive a car, and I'll take the small risk of killing, maiming myself or someone else, and I'll calculate that risk, and I'll try to manage that risk. I'll try to drive safely. Yeah. Some of you may smoke, you take a risk, you work out what that risk is, and you're happy with it. Some of you drink, some of you have sex with strangers, and put your names down, get their names.
I'm a man.
Some of you climb mountains. Some of you climb mountains with heavy weights on your back. Some of you play rugby, and the blokes probably do some of those things as well. So the point is, we all calculate risks, and we're allowed to take risks as adults. So it's always a wee bit upsetting when a woman is rushed in to hospital in an ambulance where there's been a problem with a home birth, and somebody makes the comment within earshot of the woman, or has the attitude, oh, she's an idiot, what was she doing having her baby at home? Think, you've made a huge value judgment without knowing nothing about why that lady has made those sorts of choices. Okay, and the fact is the majority of births at home in this country go without complication. Yeah. So when it comes to making choices, that woman as an adult is allowed to identify her risks and say, yeah, I want to take this risk. What's the value of having your baby at home? Well, you can use your own toilet. You don't have midwives pushing you about because you're in charge in your own house. You can eat your own food. You can decide who else is there, your other children or, whatever. And you can sleep in your own bed. There's all sorts of things that when a woman's making a decision, she will value home versus hospital, or she may value a natural birth over a caesarean birth, or okay. So what have we said so far? We've talked about maternal death, how often it is in this country. The rates are low, but it still happens once every 3 days, which is quite a lot for a relatively small country. The rates are tiny compared to Pakistan or Chad or Niger, and that's something that we have to keep in mind when we think about natural childbirth. Next, we said that pregnancy is not an illness, and on the one hand, we want to manage pregnant women in terms of respecting their choices and helping them make informed choices, but at the same time, always keeping in mind this other sort of thought stream that when things go wrong, they go terribly wrong. Okay, baby death rates are 100 times higher. Okay, so the baby death rates kind of mirror the maternal death rates, but it's per 1,000 instead of per 100,000. Okay, babies die. We see a dead baby in the women's hospital. We're the biggest maternity unit in Europe, not just in England, and we we see a baby that's died every other day, okay, which is the figure that you would expect. So that's maternal death. Any questions before I go on to the next topic, or any reflections or any thoughts? Anybody learn something? Nobody. That was productive.
What country's got the lowest rate of maternal death?
Finland, Norway, Sweden.
And what would that be?
The figure, I can't remember, it's 9 or 10 per 100,000, something like that. Yeah. When you get down to small numbers, it's hard to make comparisons. You know, what's the difference between 9, 10 and 11, kind of thing. Because when you're dealing with small numbers, one extra death adds quite a lot to you.
Is there any reason why that's the case?
In different countries. Well, that's what I'm coming on to. So the next bit then is, why do these women die? And how does that affect me? There's a marked difference between what happens in a developing country and what happens in a developed country. In the developing world, what would you guess the causes of maternal death are? Yep. So obstructive labour, and the two things are really consequences of obstructive labour. What are those two things? Yeah, sepsis,
Hemorrhage,
and hemorrhage. When you get sepsis in the womb, in the uterus, it's terrible because it's deep sepsis, and placental tissue has got all sorts of funny vasoactive things in it, which gives you a sort of consumption coagulopathy type of syndrome. So multi-organ failure happens early in the sepsis of childbirth. Okay, so sepsis is a huge thing in the developing world in relation to childbirth. In this country, since either 2009 or 2010, a bug called Group A, Streptococcus, a particular virulent form, is making a comeback of the form that we haven't seen since the 1930s. Okay, and this is what causes childbed fever. It used to be called a petrel fever. Okay, and I saw a lady in the Birmingham Mail from a couple of months ago who, I think she was a patient at Heartlands, who had gone home the day later that day. She felt shivery. Her father said she had rigors. He came round and he couldn't open the front door because she was lying behind the door. The other feature that she'd mentioned, which again is characteristic, is she had large muscle pain. She had thigh pain and buttock pain. Okay, and so beware of potentially septic women who have had a baby or around the time of having a baby. And we tend to, in our hospital, we tend to overreact to women who have features of sepsis. You know, and it's things like, you know, SATs under 90, pulse above 120, respiratory rate above 25, urine output less than 25, all of those sorts of things, you know, triggers a major sepsis protocol. So we tend to over-treat these women. And we've seen a lot of cases of this virulent form of Group A strep making a comeback. Okay, so sepsis and hemorrhage are the things that we see in the developing world. Now, let me just say a little bit, I'm going to use this doll and pelvis a little bit more later on. A woman who's standing up, her pelvis will be in that position. Okay, this is the curve of her spine, and this is her bottom on here, and her birth canal points back the way. The vulva is on there like that. Okay, so the baby has to go through a number of manoeuvres to get through this pelvis. The problem that we have as bipeds is we need a solid pelvis. We need a solid ring of bone, because when we stand on one leg to put the other foot in front of the other, our pelvis is what supports our body weight. Okay, four-legged animals have got floppy pelvises. They don't have to have a solid ring of bone. So our type of obstructed labour doesn't happen in sheep and cows and so on. They get a slightly different type of labour problems in labour. So we have this solid ring of bone. The most miraculous thing that we know in the whole universe is a grey lump of jelly, and it's inside there, okay? Because that's where we all live. And in there, we damage that, and one single claim against an obstetrician for a baby with cerebral palsy, how much does that cost you, the taxpayer? And we get it wrong, 6 million quid for one baby. Okay, that's the payout. With 800 million a year is what obstetrics costs you in England and Wales in terms of litigation. All right. So protecting that lump of jelly, the problem is you've got this almost solid, not quite solid, head that has to get through this solid ring of bone. Okay. It negotiates a complex series of manoeuvres, which I still find the whole engineering and the whole thing extraordinary. Baby's head engages, facing sideways in the pelvis. It then descends into the mid-pelvis, and because the head is sort of rugby ball shaped that way, it can't get out of the bottom of the pelvis. It has to rotate, and so it rotates 90% of the time that way, where the occiput is up, so that's the occipito-anterior position. The head then flexes like this to bring the smallest diameter of the head, this one here, the suboccipito-pragmatic diameter, down through the pelvis. Now, there is where the baby delivers obstructed labour, the head. And as you can see, when the head delivers, that's where the shoulders should engage in the pelvis. The shoulders now have to do the same as the head's done, and of course your shoulders are on the other way from the long bit of your head. The long axis of your head's that way, but the long axis of your shoulders is that way. So you've now got to rotate to the side for the shoulders to come out. Anterior shoulder first, posterior shoulder, and then that's the baby. That's the basics of the engineering of the pelvis, but it's a lot more complicated than that. And there are so many steps at which that whole process can go wrong, and that's where labour obstructs. Right? The commonest reason for labour obstructing is the head goes there, and instead of rotating to the OA, it rotates to the face to pubes position, where the baby faces up the way. When the baby faces up the way, instead of bringing the nice 9 centimetres of the suboccipital-pragmatic through, it brings through 12.5 centimetres of the subfrontal occipital diameter, and that's why that gets stuck. And that's the commonest cause of an obstructed labour in the world. There's others. If you have malnutrition, you can get rickets of your pelvis, and if you've got a rickety pelvis, it'll be contracted and the baby gets stuck. When labour gets obstructed, 2 things happen. The baby eventually dies, and the uterus becomes metabolically exhausted, and so it can't control the blood loss when the placenta comes out. And that's why you get hemorrhage, and that's why you get sepsis. In this country, you'll hear women who say, I was in labour for 4 days. Those doctors and the women, they were terrible. They did nothing. I was there for 4 days. No woman in the UK has been in labour for 4 days since the 1950s. Okay, that sounds like an arrogant statement. I think it's a true statement. Okay, a woman can be in the latent phase of labour, which is incredibly painful, and from a contractions point of view, will feel like labour, but she's not in the active phase of labour until she's 3 centimetres dilated with a fully effaced cervix. So from that point in time, that woman has 12 hours to labour. If she's not delivered within 12 hours of the onset of labour, in this country, she will have a caesarean section. And very few women at that stage say no. Okay, so she will have a caesarean section. So we do not see obstructed labours. If you go to Malawi, women, which is a developing country, but a fairly developing country, and if you go to Malawi, you will see when a woman pitches up at the maternity hospital, it means she has an obstructed labour. Why? Because on average it takes 7 to 10 days to walk to the hospital. And she will start walking when she's in labour. She'll stop and have her baby in the bush with her birth attendant, and then she'll go home. If she gets to the hospital, she's got an obstructed labour. Okay, now think about it. That baby's stuck in there. The only way that the baby by day 7 will deliver, baby dies, and then the head softens and the baby comes out. She gets gangrene of the uterus, she gets multi-organ failure very, very quickly, okay, and dies. Remember what I said, placenta is a magical organ. You know, it behaves like a liver, it behaves like a lung, it behaves like a kidney, it does all sorts of things, but placenta makes things that activate your clotting cascades and your inflammatory cascades. So when you do things to placenta like get it infected, that gets into your bloodstream and makes you very ill very quickly. Okay, so it means you bleed to death, or you get multi-organ failure from sepsis. All right, that's the developing world pattern of problems in childbirth. In the last 15 years, each of those things are now making a resurgence in this country. Okay, they're making a huge resurgence in this country. So they were developing world problems, they're becoming our problems again. Okay, now in the developed world, apart from those things, what do women die of in childbirth? What's the single commonest cause of maternal death? Sorry?
Comorbidities is the one.
Okay, you're not wrong. You're not wrong, but it's not the single.
That's not the right answer.
But it's not the single commonest cause. The comorbidity is hypertension of pregnancy. And how do women die from hypertension in pregnancy?
Preeclampsia.
No. But that's what, if I ask a young obstetric audience, that's what they'll tell me as well. So you're young.
That is true. I will always be young.
What do you die of? Subarachnoid hemorrhage. Now that's really, really, really important. All right. Last year there were 33 maternal deaths in England due to subarachnoid hemorrhage. Okay, it's the commonest single cause of maternal death. All right. What percentage of those had substandard care? 100. Every one of them, opportunities were missed that could have made a difference. Now here's the thing. When I do a ward round and I see a woman who's got hypertension and she tells me she's got a bit of a headache, I sit down and the midwife says, "Oh, there he goes again." He's sitting chatting to the patient and they stop paying attention. I was like, "Oh, I'm not chatting to the patient, I'm taking the history and I'm trying to make a diagnosis because I want to know, is her headache just part of preeclampsia or does she have a subarachnoid hemorrhage?" Now, I'm guessing I don't need to tell this audience, but repetition's a great thing, so I'm going to say it anyway. Subarachnoid hemorrhage, the one that you want to diagnose is not the obvious one. You want to diagnose the herald bleed, right? Because that's the one where a neurosurgeon or a neuroradiologist can work his or her magic and stop the patient dying. Okay. Once the patient comes in with it, oh, that's an obvious subarachnoid, sudden onset headache, and she's unconscious, it's too late. All that you're going to do is ventilate her and ask the family if you can have her kidneys. Okay, so think about it. How do we not miss subarachnoid hemorrhages? And in each of those that died, it's the herald bleeds that were missed. Okay, the patient saw someone who could have made the right diagnosis and they didn't. All right? So pregnancy is a vulnerability for subarachnoid hemorrhage, is the big learning point there. And I'll say, I'm embarrassed saying this to this audience, but the only consistent feature when you look at what symptoms have diagnostic sensitivity, the only consistent feature is sudden onset. Okay, severity doesn't predict whether it's subarachnoid, location and character of the headache does not predict it, only sudden onset. Okay, in every study, looked at what symptoms to look for. Right? If someone has a sudden onset headache and it reaches its maximum intensity within a minute, you've got to think of subarachnoid hemorrhage. For every 10 people that have a sudden onset headache, 9 of them will not be having a subarachnoid. Okay? And that's the problem, because you'll say, I've done a CT and a lumbar puncture on 8 patients now with these sudden onset headaches, and so I'm not doing the next one, and the next one will be the one. Okay? You've got to, we have no other way of diagnosing it other than if you take everyone with a sudden onset headache, they need to have a CT scan. CT will pick up 90% of those, and you've got to do a lumbar puncture in the other ones, right, to pick up the rest. Okay, if that's negative and you've got a really good history, you might want to discuss whether they should have angiography or not. Okay, but sudden onset headache. So you see a pregnant woman with a headache, your first question is, tell me, how did the headache begin? Was it sudden, or did it just build up gradually? And of course, most people say, oh yeah, it's kind of been building up all day. That's fine, you can relax a little. Okay, but sudden onset headache. And if you go away with nothing else tonight, think about that. 33 women, young healthy women, subarachnoid hemorrhage, dead. Okay, and if you can pick up the herald bleed, then a neuroradiologist can do whatever they do to them, or a neurosurgeon can clip them, and hopefully problem solved.
How many subarachnoids were there that didn't die?
Don't know.
Because there must be still
Oh yeah.
a few that
Oh gosh, yeah. We've
have
seen
disability.
in the last 18 months. Personally seen 3. I've got colleagues that have seen others, so that's in 18 months. But you've got to have a low threshold of suspicion. I gave this lecture once. It was 2001. At the Women's, a lecture on subarachnoid hemorrhage and pregnancy, and one of the registrars, who's now a consultant in the West Midlands, came up to me afterwards and he said, "This is weird." He said, "I had a headache like that a couple of days ago." And I said, "Tell me about it." So we went over to Selly Oak, it was, and it was I've forgotten his name now. City Steve Sturm, Steve Sturm, yeah, that's the one. Yeah, and he he had 3 aneurysms, one of which was leaking, and I thought, gosh, that was just at the end of a lecture. So probably shouldn't say any more about that. Give away his identity for your periscope. So subarachnoid hemorrhage. Now, there are 2 causes of maternal death which I should mention because they're parallel to this in terms of numbers. They're not particularly medical. Can you guess what they are? Women, pregnant.
Domestic violence.
Yes, domestic violence, right? As a woman, your highest risk period, the time when you're most likely to be murdered by anyone, is A, by your partner, and B, while you're pregnant. Okay? There may be psychosocial reasons for that, there may be hormonal reasons for that, there may be any number of reasons, but it's a which is, this is my posh accent. But the second cause, which is not medical, is by the woman's own hand. Okay, is suicide, self-harm. You know, people talk about postnatal depression. If you work with women who have emotional health challenges, you'll find it's not postnatal depression, it's during pregnancy as well. But women during pregnancy are supposed to be happy and positive about it. No, you're having a baby, yeah, I'm having a baby. And so it's much, they tend to mask symptoms of depression. You know, again, I shouldn't have to say to this audience, I want to say it anyway, depression, and certainly in pregnant women, is not about being sad. It's about the mind not working properly. They can't organise their thoughts. They can't plan things. They don't feel motivated. They don't feel able to do things. Sometimes it comes out as anger or irritability. Okay, and you know, as health professionals, we have to be kind of sensitive to those things and think, you know, when you meet a difficult person, you know, what is it that's making them difficult? What's in them that's making them uncooperative or irritable or you know, whatever? And it may be that what they need is someone to actually sit down and listen to them and see how they feel, because these women go on to feel they can't cope and take their own lives. So it's an important thing to keep it in mind. All of the other causes in developing country relate, as you said, to comorbidities, relates to things like cardiac disease, diabetes, pulmonary embolism, and various other medical conditions that at one time we told women not to fall pregnant. Now, you know, we don't do that. Okay. I'll tell this story just to give you an example, because again, if you're the first health professional that comes across the pregnant woman who's collapsed, you may say some unkind things, or you may have some unkind thoughts. And it's just to give a little perspective from one of my patients' point of view. I remember when I first came to Birmingham as a consultant in 1999, a girl who was 21 years old, and she came with the boy that she'd been with since she was 14 years old. They had a very strong relationship because she wanted to ask about the risks of pregnancy. And the thing about her, I'll never forget her, is that she was born with some form of dysplastic mitral valve. And so she had a mitral valve replacement. Now, you may know that Birmingham has an absolutely unique track record in terms of children's surgery in the 1970s and 1980s. So we now have a huge cohort of pregnant women whose circulation we don't understand, because they've had complex surgery, you know, when they were babies in the 70s, 80s, and now 90s. And now pregnancy comes along with all its huge fluid challenges and circulatory changes, and these women bring enormous complexity. So next to this particular girl, was 21, she had a dysplastic mitral valve which was replaced, but as she got older, her heart grew bigger and her heart began to fail a little bit, and as the mitral ring got bigger, they needed to replace it again, so they gave her another mitral valve. By the time I met her, she'd had 3 mitral valve replacements and had huge atria. Because she had huge atria, she had constant atrial fibrillation. Because she had atrial fibrillation, she'd been on amiodarone, which had given her dysthyroidism and also gave her diabetes. She'd also had a myocardial infarction. She'd occluded her left anterior descending branch of her left coronary artery in one of the operations that she had, and her risks were huge. And what I said to her was, well, your pregnancy risks are a bit unknown, but we do know that between 20 and 24 weeks, when you get massive fluid shifts, you have a risk of developing heart failure. And I said, and here's the worst case scenario that I can think of. A baby becomes legally viable at 24 weeks gestation. Pregnancy lasts 40 weeks. Your baby becomes legally viable at 24 weeks. I said, let's say you go into heart failure at 23 weeks. And let's say we manage to treat that medically for a few days, and then we deliver your baby at 24 weeks. Now at 24 weeks, the figures then was only 10% babies survive at 24 weeks. It's now actually 60%. And most of those 10% will have problems, either blindness, deafness, learning difficulties, or movement disorder. Okay, so worst case scenario, you go into heart failure at 23 weeks, we deliver your baby survives, but is blind, deaf, has learning difficulties, and can't walk, and has seizures every night, and you die. It means that your partner is left with a disabled baby for life, and you've gone. And I kind of thought that I pretty much said the right things to convince her. And she said to us, so I'll write all this down, I'll send you a letter, you go away, you think about it, come back and talk to me in 2 weeks' time. She came back 2 weeks later and she said, Dr. Pirie, she said, I'm so glad to talk to you. She says, I understand everything you've said. She said, the first thing is, you probably don't realise that I've been closer to death than most people in my life. She said, so every time I've gone for an operation, I've been told that I may not wake up. She said, the second thing is that for me, my life has no value unless I have a baby. Now, some people may think that's ridiculous. Don't make value judgments, because she meant what she was saying. And she decided to have a baby. And she did have a baby. She went on to have 2 babies. Did quite well. I'm not going to tell you the end of that story because it does have a sad ending, right? But she survived her pregnancies. Is the main thing. So heart disease is an important cause of maternal death, and in Birmingham in particular, you live, work somewhere where we have an unusual cohort of women who on the outside look completely normal and healthy, but who go blue very easily and their hearts stop very easily, and they get heart failure every winter when it gets cold. Okay, so that's a group of women to keep in mind. So, what have we said so far here? The developing world pattern is obstructed labour, baby gets stuck, dies, you get sepsis and or hemorrhage, and you bleed to death or you get multi-organ failure. Right? That's the developing world pattern. That's what accounts for those 1 in 20 women who die. In this country, we're seeing a resurgence of those things, so we've got to be aware of them. Okay, but the most common cause is subarachnoid hemorrhage. Okay, so you see a woman with a headache who's pregnant, be very careful. See her quickly, treat her with respect, take a careful history, and have a low threshold of suspicion for subarachnoid hemorrhage. Okay, keep that in mind. Something happens to your circulation in pregnancy. Complicated things happen to your blood vessels and to your blood. And it's not just the brain vessels that can bleed. As I said earlier, your renal arteries change, and people can pop little holes in the renal arteries during pregnancy. So that presents with a bit of tummy pain, a bit of back pain. Okay, it's just an ache and it's not quite right, but it started suddenly. Okay, one of my former registrars, who's a consultant in the Royal London, phoned me up a couple of months ago and said, I'm going to give you this history. And she said, and it was the sudden onset. So if it's sudden onset, bilateral loin pain, I said, you're about to tell me she's got a massive retroperitoneal bleed. Yep, that's what it is. Classic. Okay. And if you're quick to diagnose it, you can get the right type of surgeon to stop the bleeding. If you're not, you bleed to death, and it's the pathologist that identifies the cause, and that's horrible for all of us. So renal arteries can pop. Another commoner in pregnancy one, again, people who work in casualty are used to abdominal aortic aneurysms. Older people, usually male, often smokers, hypertensive, whatever, and they come in with sudden onset pain, and the systolic blood pressure is unmeasurable, and the blood's either tracking up the wall of the aorta or it's in the peritoneal cavity. Right? And so things like that don't happen to young people, but they do every single year in pregnancy. Okay, so Christmas 2007 was my personal last one. Woman came in, she was 28 years old, and she was 28 weeks pregnant, was the thing I can remember. And I said, tell me about your pain again. She said, I was standing up like this, it's Christmas Day, and I was showing somebody my bump. And I turned round to look at them, and as I turned round, I got sudden pain between my shoulder blades. Okay? Sudden pain between your shoulder blades. I thought, well, the likely thing is it's muscle. Aortic valve, and I'll never forget hearing it because I felt like I was stuck to her chest, and the hairs in the back of my neck stood up, and I thought, oh my goodness. She was transferred over to coronary care at the QE. We all went over, we delivered the baby, and then the cardiothoracic. Some of them are really grumpy. I remember that. But it's a happy occasion for the baby. And the scoop team came over and took the 28-weeker back to the women's, and they replaced her aortic valve and her aorta. She dissected her thoracic. Beware of sudden onset pain in pregnancy, in the loins, in the chest, in the abdomen, and between your shoulder blades. Okay. The other sudden onset event in the abdomen in pregnancy, and this one is unique to preeclampsia. Woman with preeclampsia, so she's got a bit of high blood pressure. She phones the 999 ambulance because she's got a bit of epigastric pain, and then she collapses. All right. What's she ruptured? Her liver. All right, her liver. And what happens? Epigastric pain is where you get liver pain. Liver pain, your liver is a foregut structure. Its innervation is foregut. So pain from the liver is always referred to your epigastrium. Okay, just like appendix pain is always referred to the umbilical area. Somebody who's got early appendicitis, that's where it's sore. It only moves over to the right when it goes all the way through the appendix and touches the peritoneum. Okay. Likewise, if someone tells me they've got pain here, it's not their liver, it's their gallbladder. Okay. If the pain's here, I'm thinking it's liver. And so epigastric pain in preeclampsia is a sinister feature, and it's a mark of fulminating preeclampsia. Right? Lady spent weeks in ITU. She came from Wolverhampton and ended up in ITU. Obstetric collapse has a huge variety of causes. If someone collapses and has a cardiac arrest, what's the different things that you need to do because she's pregnant? Left lateral. Okay. How much left lateral? 15 degrees. You need quite a lot. There's anaesthetist did a study of left lateral tilt. Nice little study where protractor went around and measured how much, and nobody ever actually got the right amount.
Are you better with manual displacement that road actually?
Okay, if you can confidently do manual displacement, so if you know what you're feeling and you can feel the uterus and wobble it over, then yes, that helps a lot. But enough left lateral tilt, either folding up blankets or pillows or a Cardiff wedge, an obstetric wedge, anything like that. But you need a good degree of tilt to actually get the uterus off the vena cava. The problem is that the pregnant uterus falls onto the vena cava when you lose consciousness, and it obstructs your venous return. No venous return, no cardiac output. Okay. In the past, we used to try CPR for 45 minutes before we delivered the baby. Then people began to notice that sometimes when you delivered the baby, the woman all of a sudden recovered. That delivery caused recovery. And at first this was case report stuff, then it became case series stuff. Now it's part of the national guideline for cardiac arrest. So now we say after 5 minutes. So it's so important to time this, because at the 5th minute of CPR, if you've not got a cardiac output, the baby needs to come out. Now, all of our kits, all of our cardiac arrest kits have got a fixed blade scalpel on them, so you don't need to fiddle about, fitting it. And the woman's effectively dead, so you don't need an anaesthetic. So someone's managing the airway, and what you would do is a midline laparotomy. Okay, you would just incise the abdomen from the umbilicus to the pubis, and then incise the uterus exactly the same way. Okay, it doesn't matter if you're going to perforate bowel or if you perforate bladder, because all of that's easy to fix. Okay, but incise, 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 and get the baby out. Right, and you're not doing it to save the baby. You're doing it as part of maternal resuscitation. Okay, and 5 minutes is the magic number. So it used to be 45 minutes, and then people would go for the baby, and then the case reports started coming through. Gosh, as soon as I got the baby out, cardiac output came back. So 5 minutes, and you need to get the baby. In obstetric collapse, everything else is what you would do with anyone else that collapses. Airway, breathing, circulation. Okay, the drugs that you use for cardiac arrest, doesn't matter that the woman's pregnant, you can still give adrenaline. Okay, you can still use whatever drugs you would use. Okay, when I was a boy, it was atropine and migraine. Phenytoin. But you can use all of the standard drugs. The only thing that's different is decompressing the vena cava. Okay. Now, how are we doing for time?
Yeah, we're like another 5-10 minutes.
10 minutes. Yeah. So, what we've said so far: maternal death, attitudes to pregnant women. Is that an illness? When it goes terribly wrong, developing world patterns and developed world patterns. Beware of sudden onset pain anywhere in a pregnant woman's body. Always needs careful assessment. I wanted to say a couple of little bits in the time we've got left about childbirth, and the couple of things that can go wrong with childbirth. I know it's not an infrequent event where an ambulance tech or a paramedic brings somebody into hospital and they've had to deliver the baby, you know, in an ambulance or at home or whatnot. What I would say is the very first thing to remember is women have been having babies for millions of years. Every human being in this room is at the end of a line of successful breeders. Do you know what I mean? Everybody here has survived, the family line has survived to this point. Okay? And that's an important statistic because, you know, it's quite scary if you're not used to seeing childbirth. And, and women make it scary because the noises that they make, or they'll look at you and say, "You got to help me," or you got to think, actually, the best thing that I can do is let nature take its course, if that's all I can do, and do what I can to keep you comfortable. Pain. Pain a bad thing?
No, let you know you're alive.
So the medical construct of pain is that pain is about tissue damage and it's a bad thing, we've got to stop pain. But you wouldn't say that to a marathon runner, okay? Because a marathon runner, pain is what makes him or her actually, you know, have virtue. Right? Otherwise we'd all be running marathons. You know, and so pain in certain contexts is an important thing. We've taken a view on childbirth that, you know, we can now give, you know, opiates, we can give epidurals and spinals and all sorts of things to take away pain. Right? But it's not always what women want. And if you work with natural birth practitioners, you'll get a very, very different take on pain. Because labour is a rite of passage for a lot of women. Not for all women, but for some women. Labour is a rite of passage. And pain and how she deals with that pain is part of that rite of passage. Okay, it's transformational. It changes her from being a woman into a mother. Okay, and so for an awful lot of women, you have to recognise that. So when we throw drugs or epidurals because we can't be bothered supporting someone, or one of the worst things is, it's one of the problems we're having men in labour rooms now, is that men always want to fix things. They, "Doctor, you've got to do something. She's, you know, my wife's in pain," or, you know, "What are you going to do about this, doctor? You've got to fix it. We can't deal with that." And in actual fact, do you know what? Women have been doing this for millions of years, and your wife's actually discussed all this with her midwife beforehand, and she wants to do this. Okay, and she wants you to support her. So when she's screaming, that's part of her trancing, right? And if you watch how natural childbirth practitioners work, they're very, very good at getting the woman into flow. Right? They get her into a state of consciousness where she does scream, and then she becomes almost unconscious between. And how do you create that atmosphere? It's about having a darkened room. It's about not having lots of people coming in and out of the room. And most of all, it's about you being a good coach. You know, if you're coaching a marathon runner, you don't throw opiates at your marathon runner. You know, you say, "You're fantastic, this is really good, keep going, you're doing brilliantly," or something like that. All right? But the fact is, labour is about good coaching. All right? And yes, I'm a man. Yes, I've never experienced childbirth, but I do watch it 8,000 times a year. And at the end of the day, you know, this is true for an awful lot of women. Okay, yep, there are women that come and say, "It's fine, I don't need any of that rite of passage nonsense, just give me a section, or just give me an epidural." And as long as she knows the pros and the cons and the options, that's up to her. But if you're attending someone who's given birth in an unusual place, the car park, an ambulance, at home, keep that in mind, create a good atmosphere. Le Boyer was a French obstetrician in the 1960s who everybody thought was a mad hippie because of his views on oxytocin. Oxytocin is made in the hypothalamus of the brain, in the supraoptic nuclei, and the paraoptic nuclei in the brain, and it's released from your posterior pituitary gland. Okay, and we know that short little monopeptide makes your womb contract. A woman releases oxytocin during childbirth, and in 2 other situations. What are they? And of the 3 situations a woman releases oxytocin, and what do they have in common? So one is during labour. Be brave.
Orgasm.
Yeah, it's during female orgasm. Okay, during female orgasm, you have 10 to 15 times the plasma levels of oxytocin. All right. Third occasion,
You the baby?
breastfeeding. Yeah, it causes the milk letdown reflex. Oxytocin is what causes milk to squirt. Okay, it causes the milk letdown reflex. Those 3 situations are bonding situations. Okay. Men have the same oxytocin levels as women do all the time during orgasm. Okay, and one of the reasons, this was a huge mistake that male gynecologists made when they used to use testosterone implants years ago, is that male libido is based on sex-seeking behaviour. Okay. And one of the hypotheses for why men seek sex is because they want those oxytocin levels, because they make us feel connected, they make us feel bonded, with everyone's at peace with the world when you get a lot of oxytocin. Does anyone know what oxytocin has been marketed for recently in Germany?
Antidepressant?
Close?
Antipsychotic?
No? Even closer. They spray it in nightclubs to stop men fighting. You know, you inhale it, right? You inhale it. And it stops men fighting. Right? If you put oxytocin in rat cerebral ventricles, the rats all start like having parties.
It don't work. I was going to say it don't work with Broad Street. I know that for a fact, and I can provide the evidence. Broad Street.
So think about that. You know, labour, rite of passage, oxytocin. How do you create a good atmosphere? Le Boy in the 60s had these ideas about childbirth, and people thought he was mad, and he's absolutely right. And we have lots of natural birth practitioners who can do this, and they're really good at helping mums. I'll not say enjoy labour, but have what they look back on as a good experience of labour, and you know, feel that we've done all the right things. All right. So if you're in a situation, a woman having a baby, keep calm and think oxytocin, and you know, create a nice atmosphere. Don't look scared. Support her, and support her through her contractions. Without going into the details of the mechanism of labour, what matters is what's kind of coming down, right? You really do need to get her to hospital if it's not a head that's coming down, because if it's a breech, or if it's a foot, or if it's a compound presentation, then that's more complicated in that it carries bigger risks to the baby and to your mum. But if it's a head that's coming down, just remember, most of the time this will end well. And if it doesn't, you've got plenty of time to get her to hospital. Think Africa, 7 days to walk to the hospital, right? 12 hours before you've got an obstructed labor. Okay? And most of the time you don't have to do anything. That should be no surprise. Women, you know, in Dudley Road have babies at the end, in the phone box at the end of Dudley Road, just up the road from City Hospital. You know, women have been having babies in fields, in all sorts of places for a long, long time. Okay, so they've got time. So create a good atmosphere. Do you carry scented candles?
Me personally? Yeah.
So create a good atmosphere. If it's the head that's coming in, you don't have to do anything, because she'll do it all. Her body knows what to do. Do you help someone when they go for a poo?
Sometimes.
But most of the time, you don't have to. Most of the time, you know, it just happens, and it's the same. The expulsive reflex will happen in exactly the same way. If you do want to do anything, a good thing as the head appears is to help keep it flexed. Okay, so by keeping the head flexed, it keeps the smallest diameter coming through. The temptation is to do this. Got to get that head out, but what you're doing then is bringing quite a big diameter, right? Maybe the biggest, which is the mental vertical 13 centimetres out. Okay, so don't do that. Do the opposite. Keep the head flexed. And then what should happen is when the head's delivered, in the next contraction, the head should turn to face one of the mum's thighs. That's called restitution, and that's just the shoulders doing what the head's done. Okay, and deliver the anterior shoulder first. You don't have to pull, because the mum will usually do everything on her own. But if you do want to do anything, take a mental vertical grip, and then that shoulder should come out from under the pubic symphysis. And once that shoulder's out, nothing will go wrong. Okay, as far as the baby's concerned. Okay, and that's it. What do you do with the placenta and cord? You can leave them connected and wait for the placenta to deliver. Okay, delayed cord clamping confers measurable benefits on the baby, especially premature babies. Okay, and sorry.
Still got to do it, shoulder dystocia.
Yeah, come to it. So placenta and cord, you don't have to do anything. If you do want to do anything with the cord, you can get a pair of shoelaces and you can tie the cord and cut in between, or you can just wrap the placenta up beside the baby if you bring the baby to hospital. Okay, but the whole process most of the time happens without anybody having to do anything other than be humane, create a nice atmosphere in the room. Now, I'm just going to touch on 2 complications and then I'm finished. Is that okay? Can you cope with that? So, one is shoulder dystocia. Right? Shoulder dystocia is when the head delivers, but the shoulders don't. Right? The clue that that's going to happen is baby bites the mum's perineum. So there's the first check. There's the back of the vulva, and the head comes to there, and then it chews her perineum. Okay, I'll start doing that on the perineum, and that tells you the shoulders are not engaging. Okay, now that's a scary complication if it's a real shoulder dystocia. If you can move the woman to hospital, great, but you probably shouldn't delay in performing manoeuvres that can help deliver the baby. And the 2 most useful manoeuvres which work are suprapubic pressure. Okay, so feel her pubic symphysis with the back of your hand and go above it, right? And rock the shoulders down into the pelvis. And the second thing is what's called McRoberts position. Can anyone demonstrate McRoberts position?
Get a knee while
I'm
you're
too
in.
stiff to do it, but you can get is to get your knees right up behind your ears. Yeah. So ideally, you will have 2 people to do that. Now you're staying nice and calm, okay? And you say to mum, now look, everything's fine, and your baby's going to be fine, right? But your baby's shoulders are a bit stuck, and I need you to help me. And you say to dad, I want you to take this leg and very gently to push it back against mum's chest, right? And either you or if you've got another birth attendant can do that for you. Don't suddenly push the leg back. You can get sciatic nerve damage and you can get hip dislocations and all sorts of things, but sciatic nerve damage is the commonest for people that do that. So gently push both legs back. You're in control. You're telling mum everything is going to be absolutely fine. It doesn't matter how you feel inside. Everything's going to be fine. We're going to do this, and the baby's going to come away soon. This is quite common. Right. McRoberts position and suprapubic pressure. Okay, that will deal with 70 to 80% of shoulder dystocias. Most shoulder dystocias that you're likely to encounter, you will deal with those 2 manoeuvres. Okay, and anybody wants to do a wee bit of that afterwards, let me know, and we can quickly do it with this doll and pelvis. Okay, it's life-saving because when the shoulders have got this far in the pelvis, the umbilical cord's being compressed, so your baby's not getting oxygen at that point. Right, that's why shoulder dystocia is such a problem. The other problem that comes with shoulder dystocia is that some people grab the head in the panic and they try to pull the head. Right? Why that's a problem is the upper cords, C5 and C6 of your brachial plexus, get stretched, right? And you end up with Ehlers palsy. And that's most of the Ehlers palsies that we see resolve spontaneously within a day or two, but some of them, the plastic surgeons end up doing nerve grafts, and a lot of them don't do well, so the babies still have a weak arm. Okay, but that can be prevented by not panicking and pulling on the head. Now there are other manoeuvres, but I think stick to McRoberts and suprapubic pressure. All of the other manoeuvres involve getting a whole hand into the birth canal, and you know, I think better to try to get the patient to a hospital in those situations. Okay, with a shoulder dystocia today, anybody that's interested, and but it's so different when you're in theatre and it's just as part of a rotational forceps procedure, and the woman's got great analgesia and doesn't even know that it's happened. Do you know what I mean? It's a very, very different different situation. Last thing to say about shoulder dystocia, sometimes it helps to get the woman onto all fours. You know, if you've got a kind of Western view of childbirth, you'll think that women give birth lying on their backs with their legs in the air. It's not what you'll see in traditional societies, and there's a lot not right about it. Okay, that position, the lithotomy position, was actually only developed since the 1600s for doctors, for us to do things, you know, to repair perineums, put forceps on, and all that sort of stuff. Right? But a lot of women prefer to give birth squatting. Right? We have all sorts of devices that mums can hold on to and give birth in that position. That way, gravity helps, and the pelvis opens up. Okay, when you lie down, your tailbone, your coccyx gets squashed up when you lie down, and so it flattens the pelvic outlet. So either getting the woman to squat can sometimes help, or getting the woman onto all fours on the ground can sometimes help. Okay, so think about different positions. Think McRoberts and think suprapubic pressure for most shoulder dystocias. That do the trick. But try not to panic, grab the baby and pull, because you might get an Ehlers palsy. The final emergency that I wanted to mention was you deliver the baby and mum's happy, and she's holding her baby, and then dumps her entire blood volume onto the floor. If you've seen obstetric hemorrhage, you'll know it can be really scary. Okay, and I was a physician before I was an obstetrician, and I'll never forget thinking, hemorrhage doesn't scare me. You know, I used to work in the esophageal varices unit and stick all these things in, and you know, these people with bled loads and whatnot, until I saw obstetric hemorrhage. And when you see a young, completely healthy woman, you know, dump her blood volume through the vagina onto the floor, it really is scary, but it won't stop. Postpartum hemorrhage, then, there are kind of two groups of women. There are the tricklers and the gushers. Who dies? The tricklers, yeah. The gushers, everybody spots it, everybody, you know, all the rest of it. It's the tricklers that die. It's that horrible sound that you hear on the floor, like somebody's just left a tap on a little bit, right? And you hear that sound, you uh-oh, because that keeps going and keeps going and keeps going, and she's found dead in bed a couple hours later because she just trickles it all out. Right? So beware the trickler. There are two principal causes of a postpartum hemorrhage. The commonest is that the woman just hasn't contracted. Right? Once you get the woman to contract, you'll stop the hemorrhage. The less common is trauma surgery in the birth canal, either her perineum or her cervix, or she's ruptured her uterus. You know, there's bleeding somewhere from uterus to vagina. Right? But most of the time, 92% of the time in this country, a primary hemorrhage is due to an atonic uterus. So the womb is a great big thick muscular organ in a term pregnancy. Placenta comes away, the placental bed would hose blood but the uterus contracts down around it, and that closes off the blood vessels. Okay, your cardiac output in term of pregnancy is 7 or 8 litres per minute. Okay, much more than the normal resting cardiac output, and 1/3 of that goes through the uterus in a term pregnancy. It's a lot. Okay, so when you've got an atonic uterus and you're bleeding, you've got to get the bleeding to stop. Anybody know the simple first aid things to do to stop that happening?
Try and rub up a contraction.
Try and rub up a contraction. So you know, again, everything's in good manner with the mum. You say to mum, everything's going to be fine, but you are losing quite a lot of blood, and we need to stop it. So I need to put my hand on your tummy. You put your hand on your tummy, you feel the top of the uterus, which is usually, after a woman's had a baby, it'll be at about the level of her belly button. It'll be about 20 weeks size once the baby's out. Okay, so feel around the level of the belly button, and then massage the uterus and push the uterus down into her pelvis. Okay, so you push it down into the pelvis. That will stop most bleeding. Okay, now if you're in a situation where you have access to drugs, you can give her drugs that will help the uterus contract. Okay, the standard one that every midwife carries is symptometrin. Okay, symptometrin is 5 units of syntocin, oxytocin, and 500 micrograms of ergometrin. Okay, it will make the uterus contract. Ergometrin's contraindicated in hypertensive pregnancy because it can put your blood pressure up, but that's not a bad thing in a woman who's about to bleed to death. Okay, so for a woman who's having a significant postpartum hemorrhage, there's no contraindication to ergometrin. Okay, so symptometrin, and you can give 2 shots of symptometrin. Okay, if you then have oxytocin, or if you have prostaglandins like Prostin, mifepristone, these are prostaglandin E1 analogues, stable E1 analogues, they will make the womb contract. The woman can take them orally, but they'll make her vomit, or you can put it up the vagina, or you can give it per rectum. Okay, and obviously you explain what you're doing in a conscious womb. So you either put it up the vagina, up the rectum, or she can take it orally if she's not happy with you doing things down there. Okay. Ultimately, she needs to get into a hospital environment. And behind all this, you're thinking of your usual resuscitation things and hypovolemia, you know, airway, breathing, circulation. You're giving her oxygen. If you've got 2 large bore veins in, are you giving her fluid? Okay. A woman who's bled for any length of time will develop a DIC, consumption coagulopathy type of thing. So you have to get a handle on her clotting. We still have between 10 and 20 hemorrhagic maternal deaths in England every year, and one of the common reasons is that people tried to stop the bleeding but didn't notice that her blood wasn't clotting. Okay, and remember, you don't have to lose a lot of blood in pregnancy because of what I said about placenta. Placenta is loaded with thromboplastin, and when that's released into your circulation, you very quickly use up all your clotting factors. Okay, so she needs her clotting fixed. Yes, ma'am.
Can I ask how much that is to do with, well, my personal favourite subject, which is blood, not fluid? I think we've learned a lot of massive lessons in trauma, management of trauma hemorrhage. And obviously the maternity unit where I work, they're very good at major hemorrhage protocol, but do you think we still probably don't give enough blood in time, or do we still favour fluid over blood? Do you think that's part of the reason for the casualty?
I don't know. I mean, what I do know is that pregnant women in preeclampsia with intrauterine deaths, with any form of intrauterine sepsis, and with small degrees of hemorrhage get exactly the same pattern of blood changes. okay, and it's a bit like what you get in TTP in hemolytic uremic syndrome, without getting lost in the complexities of it. The pattern's the same in each of those. That makes me think it's to do with placental factors entering your circulation. The veins in a term uterus, I see this every week at cesarean section, the veins are really thin-walled in the uterus, and it's easy for material to get squeezed into the veins. So you've got this huge, thick, muscular organ that can generate massive pressures to expel a 9-pound baby, an 11-pound baby, so it's generating massive forces. And that happens in the uterus, and it can very easily force placental material into the circulation. And it's that pattern. Now, every confidential inquiry, we have between 12 and 15 what are labelled as amniotic fluid embolus, where, you know, fetal material enters the circulation and causes the mum to collapse, and her blood just won't clot, you know. So it's the same pattern in each of those: intrauterine death, severe fulminating preeclampsia, intrauterine sepsis, and in relatively small degrees of hemorrhage. So I think it's a placental. I think it's a placental thing. Now, the question whether giving crystalloid or blood is the right answer, I don't know. You know, the fear, you know, always have with blood is it takes time for it to develop. You know, with the 2,3 DPG thing, it takes time for it to develop its oxygen carrying capacity. Secondly, it presents a huge immune challenge, you know, to the woman. It's an organ transplant, it's a tissue transplant, effectively. And so my gut feeling is that if you can maintain her volume and circulation with crystalloid, that's the thing to do until you've got access to clotting factors. And so we would use fresh frozen plasma in cryoprecipitate. We use recombinant factor 7, which is enormously expensive and does have an association with deep vein thrombosis and potentially maternal death. So all of these things, certainly with us, involve a consultant hematologist. Mm-hmm. It's interesting because as part of our major hemorrhage protocol, we always involve an obstetric hematologist. On the days when it's a non-obstetric hematologist, it's called, they wonder why they're being phoned, you know, and it's, you know, A, it's on our kind of protocol, but B, because of the complexities around exactly what we have to replace to get her to get clotting.
And tranexamic acid?
Tranexamic acid, calcium, aminocaproic acid, mm-hmm. You know, all of these things that are things that might be lifesavers.
Would you hypotensively resuscitate a patient?
Say that.
Hypotensively resuscitate, or what
does that mean?
So shock might hinder bleeding. Would you aim for a lower
pressure?
You
mean keep the blood pressure low? I'm only used to doing it in a hospital setting. You know, in the hospital, no, in this bit, but you're right that if you're trying to effect a transfer to an obstetric unit or something, then as long as you're perfusing her kidneys and her brain, you only need blood pressure to perfuse your kidneys, don't you? And in that sense, it might be a good idea. But once you know you're in an obstetric unit, then we're trying to get the systolic pressure above 100. Yeah. So the lessons on hemorrhage are: treat it as though it's an atonic uterus, because that's what it usually will be. Put your hand on the uterus. If you've got drugs that can contract the uterus, then use them. Don't worry about contraindications, and transfer the patient to hospital and tell them not to forget about clotting. The one other manoeuvre that sometimes helps, but if you're not used to doing it, I'm hesitant to recommend it, is bimanual compression. You know, and I mean, this sounds awful to an non-obstetric audience, but bimanual compression, you put a fist in the vagina and you put another hand above the fundus and you push the two together, and it's life-saving because it compresses the uterine arteries where they pierce the broad ligament and form the uterine arcades, and it's a very effective way of transferring a patient to hospital. The problem is, you know, if you're not used to doing it, it's not an easy thing to do or to explain to them.
Can you cause more damage? Is it something someone might do if they're literally can't
I
stop
think
the
that's
bleeding?
incredibly unlikely in a patient. And you've got to remember, she's postpartum. She's just delivered a 9-pound baby, so your fist probably isn't bigger than the baby's head. What matters is that you're gentle in how you introduce. You know, I watch people do vaginal examinations in childbirth. They've got a habit of using fingers and their thumb on the outside. And go, no. You need your thumb to get your hand. You need to get your hand into the vagina to do it. Sounds horrible in its description, but it's not as horrible as watching somebody bleed to death from a postpartum hemorrhage, and it is life-saving. So that's postpartum hemorrhage in a nutshell.
Is there any, I think I've been to a few jobs really where women are discharged the same day and they get a little bit of spotting. Is there any sort of like take-home advice that labour maternity wards leave?
Do you mean postnatally?
Yeah, sorry, after birth. Yeah, so they get, you know, like, and they say, and people have said, oh, well, you should expect this. And so, is there any sort of like, I don't know, like a guide or something with a volume that's acceptable?
What they say is that your lochia, the discharge that comes from it, should be 3 days red, 3 days grey, 3 days white, and then have gone by the 10th day. Right? After a caesarean section, you can bleed for up to 6 weeks afterwards. You've always got to take a patient's complaint seriously. You know, if she says she's bleeding, she needs assessed. You know, a lot of the time it'll turn out to be nothing to worry about, but you only know that when you've seen and assessed the patient. You know, in Birmingham we have the luxury that patients aren't coming hundreds of miles. In Aberdeen, it's a major problem because Aberdeen covers the Western Isles, and Aberdeen's in the east of Scotland. You know, so Aberdeen covers a huge landmass from the Faroe Islands down as far as Loch Lomond. And so questions like that are really important. You can't see and assess every patient. But I think I'd say always take the patient's symptoms seriously. She always needs an assessment and a discussion. You know, is she a trickler and you need to pay attention, or is this just the normal lochia? The other one's 6-week bleeding. Quite often a woman's fine, and then at 6 weeks she gets a torrential hemorrhage. That's her first period. You know, it traditionally happens at the end of 40 days. 40 days after the baby. So, I don't know if that's helpful.
No, that's fine. Yeah, I'd take anyone else in, but I just thought I'd ask.
One of the most important things I think from transferring patients and whatnot is just sensitivity and things that are said. You know, and I know you get a lot of feedback from patients, and most of the time patients are really happy with the service. Most of the time patients are really happy with what's happened. But sometimes you'll get some daft bloke making, you know, sexist, inappropriate comments about, you know what I mean, and it's just always a bit uncomfortable. You know, you've got a woman in a situation that for us we're seeing every single day. For her it's a one-off experience, you know, and she's got her most intimate parts exposed to complete strangers and whatnot. So I say manner and sensitivity, you know, and just, you know, always helping keep her covered up and that kind of thing, helping her feel safe, that you know, as to who's around and you know, who's talking to her, and especially things like, you know, if you're going to press on her uterus or things like that. When pregnant women get very sensitive tummies, you know, so they get tickly, or you can hurt them very easily. And so it's just always letting people know what you're doing and doing it carefully. And if you are going to be involved, you know, if you can't transfer a patient and you are going to be involved in childbirth, you want it to be a lovely experience, and you've got to look like you know what you're doing, because 90% of it is show, it's theatre, it's you know what I mean, it's everything's going to be fun when you're actually wetting yourself. And that's how we feel as obstetricians as well. You know, I mean, things go from great to from the normal to becoming catastrophic and
Any other questions?
or
Just
any other things that I didn't touch on.
about the tranexamic acid.
Yeah. Yeah.
Because we're ambulance.
Yeah.
For postpartum hemorrhage.
Yep, yep,
And
yep,
antepartum.
Never for antepartum hemorrhage, never for antepartum. Yeah.
Always.
Antepartum hemorrhage is usually either due to placental abruption or to placenta previa, and there's some other rarer causes. Must always come into hospital, must always be assessed. 90% of them turn out not to be a big problem, but 10% of them are. But the basic things there would always be, basic resuscitation. It's really uncomfortable. She's got fluids, and get them into hospital. Okay.
Alex, thank you very much again for a very enlightening session again. It's been wonderful for you to come back, and we hope you'll come back again in the future and deliver. Thank you, everybody.